and peritoneum of occult sac. Talking now on the bladder endometriosis, it's very important the preoperative evaluation at the level of the bladder, because with ultrasound we have to, the surgeon has to know how deep is the lesion and which is the distance of the lesions with the urethral meatus and with the intramural tract of the ureter. So, if the nodule is a central nodule, this is a 3 centimeters central nodule inside the bladder, is very distant from the ureter and from the intramural tract of the ureter. So we can consider this kind of surgery not very difficult. It's important to identify correctly the area, and with the full bladder, we go to open the bladder and we check the nodule inside the bladder, and we go to remove all the nodule, and after we restart with the reconstruction of the bladder wall in 1 or 2 layers. And this is the nodule that we went to remove. You can do it with a running shooter without problem. It's not a difficult surgery. But this is another case. It's totally different. The nodule is bigger and go laterally on the left side and go very close to the left intramural tract of the ureter. And we know exactly the distance of the nodule from the intramural tract of the ureter by preoperative ultrasound evaluation. And so we can have with the patients a different approach, and we can explain to the patients that this is a very difficult surgery, and we can explain the patients about all the intraoperative or postoperative complications regarding the stenosis of the ureter and the possibility of the second surgery and the possibility to maintain a stent inside the ureter for more than 1 month. So this is the situation with the opening of the bladder. You see at the right side is okay, because a good distance. And we know that in this point here, the lateral left side of the nodule go very close to the ureter. So we go to open more bladder, and we stay very close to the adventitia here of the ureter, very close to the ureter. And after removing all the nodule, we start the reconstruction of the bladder. This is the most difficult part of the surgery, because you see that we are very close to the ureter, and this point go exactly at the level of the adventitia. And again, we stay very close to the ureter. And cystography, after 2 weeks, usually we do a cystography after 2 weeks, and after we remove the bladder catheter, and after 2 months usually, or 3, we remove the stent. When the infiltration of the parameter go very close to the ureter, you have to remember the anatomy of the ureter. So the lumen, the mucosa muscularis, and the adventitia. And sometimes we know that infiltration at the level of the lateral parameter with the involvement of the ureter can be extrinsic or intrinsic inside. Intrinsic is usually very rare, And so usually we can try to do ureterolysis when there is involvement of the ureter, and we try to do a conservative treatment. So this is a typical left side parametral infiltration. This is the how we start to open the retroperitoneal area, and this is the final results after the total ureterolysis. You see, this is the lateral parametria, totally free. This is the ureter going here across the uterine artery inside the bladder, and we remove all the disease in this part. This is another example after a very complex surgery. This was a radical trachelectomy for cervical and paracervical infiltration with the right side ureter involvement after subtotal hysterectomy without removing of the lateral and retrocervical disease. So we went to remove the cervix, the lateral parametria. We did the job at the level of the bowel, and at the end, we did this kind of ureterolysis. And again, you see, we have to remove now all this ring around the ureter. We put a stent inside, and this is a tentative to do a conservative treatment in order to avoid the resection of the ureter. And sometimes we can do it. This was an extrinsic endometriosis. So if we remove, well, this fibrotic ring around the ureter, we can avoid to do the resection of the ureter. At the end, usually we do the indocyanine green evaluation. Now we are using the Rubina new technology, 4K indocyanine green evaluation, in order to see the microvascularization at the level of the ureter and understand if the ureterolysis is enough, or we have to do this different job. In this case, the infiltration was inside the ureter, and we went to resect this part of the ureter, checking the distance of the two parts of the ureter, and at the end, we went to do the reconstruction and the reanastomosis, the end-to-end reanastomosis, using 4 stitches with the 4-0 stitch. And this is the final results after end-to-end reanastomosis of the ureter. Sometimes we have to do this different job when there is the infiltration of the ureter very close to the bladder, less than 2 centimeters. I usually do this kind of preparation, resection of the ureter and the reimplantation. To do the reimplantation, we usually we have to free the bladder from the anterior part of the bone here. So we have to open the retius space, mobilization of the bladder, and the fixation of the bladder in the homolateral side. So in this case, we fix the right wall of the bladder to the right psoas muscle. So psoasization of the bladder in order to have the correct distance to do the reimplantation. This is the ureter, and after the resection of the ureter, and this is how we start to fix between the mucosa and muscularis of the bladder and muscularis and adventitia of the ureter. The ureter go for 1.5–2 centimeters inside the bladder, and this is the system that we use to avoid or reduce the reflux between the bladder and the ureter. And
Sorry to interrupt, sir. You have 5 minutes to cover your
perfect. I go very fast. So sometimes we have to do this kind of job, and sometimes when there is a totally compromission of the kidney, we have to remove the kidney. So on the left side, you see how we put and we close the ovarian vessel here first, and after renal vein here and the renal artery. This is the removing through the vagina of the uterus, lateral parametria, ureter, and the kidney. And at the end, the final results you see on the right side is the removing of all the left parametria here with the infiltration of the disease. Very fast on the bowel. On the bowel is important the indication. We published a lot about our indication for the different kind of treatment on the bowel. And so this is our conclusion, the M rule that we published in JMIG a few months ago. If the nodule is more than 3 centimeters with the infiltration more than 7 millimeters at the level of the muscularis, we go for segmental resection of the bowel. For nodule bigger than 3, but with infiltration less than 7 millimeters, we consider to do shaving technique. And for nodule less than 3 centimeters, but infiltration more than 7, discoid resection. So the surgical technique, this is the shaving. I want to show you the final of discoid resection. This is the preparation of discoid resection. And again, we put the nodule inside the circular stapler, and we close the circular stapler, transanal circular stapler, in order to involve the nodule inside. And this is very good for small nodule with infiltration more than 3, more than 7 millimeters. In case of nodule bigger than 3 centimeters, but with the big infiltration, we have to do this segmental bowel resection. So this is the end of segmental bowel resection, the preparation of the rectovaginal space. This is the big nodule, and the vagina is free. We go through the right side with a 12 millimeter trocar with the linear stapler. We resect, and after this resection, we can see all the preparation of the nerves. You see the hypogastric nerves both sides, on the left and on the side, and after we go to check the vascularization with indication in green at the level of the nerves, on the level of the ureter, and at the level of the bowel. And at the end, we do the small mini laparotomic approach. We go outside, we complete the resection of the nodule, we put the anvil, and we come back by laparoscopy in order to do the anastomosis by circular transanal stapler. And this is the vision at the end of the big nodule with the infiltration until the mucosa. This nodule was bigger than 3, it was around 4 centimeters with infiltration more than 7 millimeters. So in conclusion, we can say that in our complication for bowel resection is rectal bleeding 3%, anastomosis leakage, it was 1.6%, and rectovaginal fistula was 2.4%. This was the old data. The new data are really better. because the rectovaginal fistula is now less than 1% and less than 1% the anastomotic leak. So indication for surgery could be severe pain, all the patients not responsible to the medical treatment, or bowel or uterine stenosis with the functional organ compromission. And at end, with the take-home message could be that we have to start from anamnesis, clinical evaluation of the patients, skilled imaging, counseling with the patients, correct indication for medical treatment, pregnancy, follow-up or surgical treatment. In case of surgical treatment, strategy are mandatory, knowledge of anatomy, experience with for the doctor, and surveillance after surgery and management of the complication. So I want to show you just few seconds of this video of our next meeting in Italy. Meeting will be in Rome. We will be in May 2021. It's called Endometriosis 2021. And will be 4 days of live surgery and lecture. We are ready. See you in Rome. Thank you so much.
Thank you so much for that excellent presentation, sir. And we've had more than about 600 registrations.
Nice.
And we are all happy to have heard you all the way from Italy. We are sitting right back in our homes. And COVID permitting, we all hope that we can come and meet you in May 2021.
Thank you.
Thank you very much for your excellent, excellent talk. Can we move on to our next speaker? Dr. Rishma, are you ready? Yes. So it's my great privilege and honor to introduce Dr. Rishma Pai, though I'm sure she doesn't require much of an introduction. If I read her introduction, I would be talking till the end of the day right now, but I've had a good time to summarize her performance all over this thing. And she is one of actually the only person who has headed all the major organizations in our country, FOCSI, ISAR, IAG, MOGS, and she has been the assistant treasurer for the International Federation of Fertility Societies. She's a consultant gynecologist at Leelavati, Jaslok, and Hinduja, has a fellowship from the RCOG. And if I read her awards, I think we'll finish our webinar there and there. So she's got many awards and she's got many orations and multiple publications. So I hand over to you, Dr. Rishma Dhillon Pai.
Thank you. Thank you so much for the warm words. Thank you for this kind invitation, Dr. Rajiv, Dr. Datta, Dr. Abhishek. Thank you. You all have been very, very closely associated with the Mumbai Obstetric Society since so many years. And I think I'm going to need a couple of minutes to just recover from the previous talk. It was breathtaking and amazing and scary. And I think appropriate for me to begin by saying that life is full of difficulties. You have to meet them, greet them, and defeat them. And that is, I think, what all of us are tackling at various levels, including, I think, with this COVID situation. But no more is this quote more appropriate than when we go on to treating this condition called endometriosis. Widely prevalent is endometriosis. All of us know that at least 1 in 10 women of reproductive age group worldwide suffer from it, probably double this incidence in Asian women. So all around, we are surrounded by women suffering from various stages and discomforts associated with this terrible condition called endometriosis. Of course, we are going to go ahead and discuss management. But before that, there is so much that is enigmatic about this condition. What we do know today is that endometriosis is an inflammatory disease. It is the result of interactions between various hormonal, immunological, and genetic factors. But the central role belongs to local inflammation. And we can see that with the high levels of macrophages, immune cells, cytokines, angiogenetic factors, growth factors, the influence of COX-2 and prostaglandin, which we all know are inflammatory factors. And there is also contribution of oxidative stress. There's increased production of reactive oxygen species. So you can see all the elements of inflammation are there within these endometriotic lesions. Not only inflammation, there are a lot of immunological aspects of endometriosis. It's a condition of immune dysregulation. And what are these immune dysregulations that we see? These are characterized by hyperactive peritoneal macrophages with altered phagocytic activity. And this actually represents another key point in endometriosis development. This is the phagocytic ability of macrophages, which is mediated by matrix metalloproteinases. The natural killer cell activity is significantly decreased. There's some kind of an immunosuppressive effect going on here. So you've seen how inflammation is prominent. You've seen how immunological aspects are extremely important. And of course, something we are a little bit more familiar with, and that is angiogenesis in endometriosis. And there are several angiogenesis-related factors in endometriosis. There's vascular endothelial growth factor, the receptor of this VEGF, and these are able to regulate the proliferation, migration, permeability of the cells. Interleukin 17A is one of the potent antigenic factors that are being seen. Many other factors, we've now become familiar with these, the tumor necrosis factor alpha, VEGF, interleukin 8, and all of these actually get together and they trigger vessel hyperpermeability, release proteins, produce fibrin, endothelial cell proliferation, and they promote angiogenesis and fibrolysis. So you can imagine the number of activity going on in these endometriotic lesions, which are inflammatory, causing angiogenetic changes. And you can see this. This is a summary of how the vascular endothelial growth factor gene is there, which produces VEGF, causing angiogenesis. There is COX-2 gene, which is again producing prostaglandins and causes inflammation. There is the matrix metalloproteinases 9 gene, which actually brings about the debris and matrix degradation. So a whole lot of different factors happening. And you'll wonder why I'm going so much into the depths of it. The reason being that unless we understand what is going on within that endometriosis, how are we going to treat it? All of us know the symptoms are typical: pain, 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 whether it's cyclical pain, dysmenorrhea, dyspareunia, dysgeusia, dysuria. Pain is significant. Infertility is another significant problem. And today we saw, even in our previous lecture, for even with fabulous ultrasound today, you're able to diagnose even deep infiltrating endometriosis, which earlier was very difficult to diagnose. Of course, history, ultrasound, PV examination, CA125, not very reliable, but we still do it. Laparoscopy still remains the gold standard, especially with the biopsy. And MRI being used more and more, especially in deep endometriosis. Another aspect which none of us are very, very familiar with, but I hope we become more familiar with it, because I hope it is something we will have as an armamentarium in the future. So what are these biomarkers? A non-invasive biomolecule for endometriosis diagnosis. These can be picked up from the serum, plasma, or urine. And there are many potential endometrial biomarkers, for example, glycoproteins, growth factors, microDNAs, long non-coding RNAs, etc. So there are a few terms you should be familiar with, because believe me, I myself have attended World Congress on Endometriosis, etc. Initially, completely at sea. I couldn't understand what they were talking about. But over a period of time, you realize there's so much amazing research going on in the field of endometriosis. And a new area they're focusing on is proteomics. Proteomics really is a new perspective in looking at these non-invasive biomarkers. It includes all the protein fingerprints, which are used for endometriosis diagnosis. There are different protein peaks, some proteins downregulated, and by seeing that analysis, you can actually pick up early the possibility of endometriosis. What about genomics? Genomics is taking over in all aspects of medicine. Genomics really will give us another biomarker to pick up early the condition of endometriosis. We can see now that there are higher plasma concentration of circulating cell-free complementary DNA in women with endometriosis. Micro-DNA, if you read up microRNAs, there's a whole lot of studies on them in literature today, because these are non-coding RNAs and they represent major modulations of gene expression in a wide range of pathologies, including endometriosis. And this microRNA profiling, which now we are doing routinely with microarray followed by the PCR, and they can actually prove important molecules for the diagnosis of endometriosis. So we can use genomics, we can use proteomics, and a lot of non-invasive biomarkers for diagnosis of endometriosis. And just to give you a perspective, you can see here how many factors are being worked upon as non-invasive biomarkers. Different growth factors are there, glycoproteins, various angiogenesis factor, apoptosis causing ligands, hormones are there, many different things like urocortin, cell-free DNA, proteomic factors, which we spoke about, immunological factors, and you can see the number of immunological factors there are. So whole range of things which are going to be available to us in the near future. And it's all going to be about non-invasive early diagnosis, because if we can do that, we are already at an advantage starting out. Just like there is so much difficulty in diagnosis, classification is even more complex. And in fact, at the World Endometriosis Society consensus meeting in 2014 in Brazil, there was a statement which said that until better classification systems are developed, we should use a classification toolbox, which includes the commonly used ASRM classification, but that ASRM classification ignores completely deep infiltrating endometriosis. Along with that, we should use the Enzian classification, where DIE is used along with ASRM classification, or we can use the Adamson classification, which is by the Endometriosis Fertility Society. So we can actually look at an infertility-related classification with the EFI classification. So all these classifications systems are continuing to attack criticism because the women are complaining, the doctors are complaining, because there's really poor correlation with the disease symptoms, the lack of predictive prognosis, and completely unclear pathways of treating this pain and infertility. So I think we've started on a pretty dismal note, saying that there is really no great clarity and no, sort of clear solutions for treating endometriosis. And what is this causing? This is causing a widening impact of untreated endometriosis. We are unable to pick up in early age the dysmenorrhea, dyspareunia, pain, which all causes long-term impacts on sexual life, on relationship, on performances. It causes a huge amount of medical, surgical costs. There's a lot of absenteeism from work. And basically, everyone around that person is suffering. Which is why we need to treat, and we need to treat early. And we have to choose our treatment based on the age, symptoms, severity, desire for fertility, extremely important, the recurrence and prior medical or surgical treatment. So the American College has opined on adolescent endometriosis, which is very, very important because it is one of the leading causes of dysmenorrhea in adolescents. We should never fail to diagnose this. We should always look at it in any patient who has persistent dysmenorrhea not responding to treatment. And even if you do a laparoscopy in these patients, you'll find the lesions are quite atypical. They're clear or red, difficult to identify. But remember, any chronic persistent pain not getting treated easily could be endometriosis in these young girls. And in these girls, our focus is on symptom relief, try to prevent the progression of the disease, and obviously protect the future fertility. look into her need for contraception. Can we use hormones in that patient or not? And what are the potential side effects of the drugs that we are going to use? So adolescents is a unique group, but an important group in endometriosis management. All of us know endometriosis is resilient. It continues to grow. But women with endometriosis are also resilient. And we, the women and the doctors, continue to fight. And how do we fight? You could learn a number of drugs we have available with us to fight this particular condition. And we'll quickly go through some of the really important medications that we have. And you can start with today, probably one of the most important medications, that is the progestins. And these could be the oral preparations. You can see a whole lot of choices that we have today, starting probably with the most important one at the moment, Dynogest, dydrogesterone, gestrinone, medroxyprogesterone, megestrol, cyproterone, and norethindrone. So a whole range of progesterones orally which can be used. Also, we have injectable medroxyprogesterone. You give 150 milligrams every 3 months. Commonly, we've all used these drugs for many, many years. We're very comfortable, and we know all the effects and side effects of these drugs. A little bit more about Dynogest, because like I said, it's becoming one of the main drugs at the present moment to start therapy with. So this is an oral progestin used in a dose of 2 milligrams. It is approved for the treatment of endometriosis. And the important thing is it lacks androgenic effects, like many of the other 19 norprogesterone drugs. So how does this really work? It causes inhibition of gonadotropin secretion, reduction in estradiol. It produces a hypoestrogenic, hypogestogenic state, and it has anti-proliferative, anti-inflammatory, and anti-angiogenic effects, which, as we started out saying, were extremely important. And you can see we can continue to use this drug. There's a lot of experience now with long-term use, up to more than a year of use of Dynogest, and it offers an effective and tolerable alternative and adjunct to surgery, and provides even many advantages over the hormonal combined pill. So we have to tailor our treatment, of course, to each person. And this is a very, very recent opinion which has come out in 2020 itself. What about long-term safety? Because endometriosis is a condition in which we use drugs for months and years on end. So the things we need to look out for, there is a small decrease in bone mineral density can be seen, but luckily this is reversible. Once you stop the drugs, it kind of comes back. It's not severe enough as to cause extra precautions we have to tell the patient, or there is no evidence of increased fracture risk in later life. So these are all pretty important, that there are minor changes, but no extra advice needs to be given to patient except care of lifestyle, calcium, exercise, etc. In terms of cancer risk, there is no separate extra precaution that has to be taken. So a relatively safe drug, even in the long term. And when you compare it with all the other progestins available to us, you can see that Dynogest has good progestogenic activity, but no glucocorticoid, androgenic activity, anti-mineralocorticoid activity. So it's a pretty good drug, whereas some of the other cause androgenic effects and glucocorticoid effects, and are not tolerated well by the patients for those reasons. So how does this compare with oral contraceptive pills? Because many of us are comfortable with combined OC pills, low cost, simple drugs, but there's a lot of talk about not using combined OC pills in endometriosis today. And you can see that this is again a very recent opinion earlier this year, comparing OC pills with Dynogest. And OC pills do help in reducing dysmenorrhea, but they're not helpful for the other kinds of pain, whereas Dynogest helps for dyspareunia, dysuria, dysgeusia. All types of pain are improved by Dynogest. Also, COCs, we know, have many other contraindications, have side effects. And so there is also some studies, not very sure, that if you use OC pills today, later on, there may be a higher risk of deep infiltrating endometriosis. So today, most people believe that progestins may be a first-line treatment better than a combined OC pills. And again, many studies are coming up, and I'll just take you through one or two of them, that estrogen progesterones lead to deserialization, they may slow progesterone of disease. So we've used OC pills for a long time. They still have a role to play. They still do reduction of pain, but the risk of thromboembolism, high risk of recurrence, impaired fertility. Nobody can become pregnant while on OC pills. So these are the negative effects. So if OC pills have to be used, use the minimum possible dose. Again, the Cochrane review on this subject came out. And I was actually, when I saw this a while ago, I was quite surprised to say that there is insufficient evidence to make a judgment on the effectiveness of combined oral pills compared to placebo, even to placebo. And there's insufficient evidence of the effectiveness of pills compared to other medical treatments. So OC pills have played an important role, but it appears their role is now declining a bit in the management of endometriosis. Can't say the same for LNGIUS. LNGIUS is an excellent product, releases 20 micrograms of hormone every day over a period of 5 years. It brings about decreased retrograde menstruation, suppresses ectopic endometrium, has anti-inflammatory immunomodulatory functions, and is an excellent alternative in women who are not seeking pregnancy. So wonderful for long-term management in women who don't seek fertility. Also, hopefully in India soon, we'll have the etonogestrel implant. And these implants like Implanon, they cause amenorrhea, reduce the pain. You just put it intradermally into the arm and it lasts for up to 3 years, giving significant benefit. Of course, all the negative effects like irregular periods or weight gain, headache, breast engorgement may be there, but these are like slightly long acting and reasonably good benefit. How do you actually compare these implants and the LNG? So the LNG intrauterine system is for 5 years. The implant is for 3 years. They're put immediately after the period, and both of them seem to give good contraception also, and they reduce pain and dysmenorrhea. There is sometimes in between spotting and all with both the things. It is part of the side effects, but both of them seem to improve quality of life. Another newer drug we're looking at now is the selective progesterone receptor modulators, particularly mifepristone. So 5 or 10 milligrams has predominant progesterone antagonist effect. Ulipristal, we started using for fibroids because of the fear of the liver damage. We are not very, very comfortable with it at the present moment, but mifepristone is being used. Another molecule we are very familiar with, very comfortable with, is GnRH agonists, which cause hypoestrogenism. They block the ovarian estrogen production, the endometriotic implants regress, and there is usually amenorrhea. And we've often used leuprolide acetate, goserelin, monthly, 3 monthly injections, and they seem to work very well. We all know that if used for more than 6 months, you may have to give add-back therapy, preferably with norethindrone acetate, because they do cause significant loss of bone in the long term. GnRH antagonist is available. In IVF, we use it all the time, but these are injectable. And obviously, you cannot give daily injections to a patient. So fortunately now, we are getting, and it is available elsewhere in the world, the oral non-peptide GnRH antagonist, the elagolix. And elagolix in a dose of 150-200 milligram is showing excellent reports in management of endometriosis. So GnRH antagonist will be in the very, very near future orally available and will be an excellent option. Aromatase inhibitors, again, a very good promising therapeutic option, and they basically cause an inhibition of extra ovarian estrogens. Hence, they're more important in older women where there is more extra ovarian estrogen being produced. They are very good in patients who are seeking fertility treatments, and you can use letrozole 2.5 milligram daily, and they work pretty well, fairly safe drugs. So that's another option that we have in front of us. The ESHRE guidelines came only in 2014. After that, I don't think we have an update on that. So they kind of put everything together, what was available at that time. And they said the important thing is counsel women, treat them with adequate analgesia, give them progestogens, combined OC pills, and they have put contraceptive pills as level B, progestogens as level A, antiprogesterones as level A, GnRH agonists as level A. So those are very, very effective drugs. And they're basically recommending progestogens, whichever one you choose to use, as your first choice. So level A choice is progestogens. And of course, in young girls, I already said, do not use GnRH analogs because of the osteoporosis that they may cause in long-term use. What about endometriomas? All of us know that endometriomas have been having cystectomy as the first line of treatment. So surgical intervention for large endometriosis has been the standard of care. But there is now a growing body of evidence demonstrating benefit, at least no harm, in expectant management or even medical management as a first-line therapy. So try out medical management, and only if it doesn't succeed after a period of time should you revert to surgery. So surgery is going lower and lower on our choices of options available. there's actually a study about Dynogest. Does it work in cases of endometriomas? And all of us know that when you operate endometriomas, you cause damage to the ovary, reduction in the reserve of the ovary. And here there's a good study treating patients with Dynogest or Dynogest and OC pills combination. And they found that endometriotic cysts was significantly really reduced in the Dynogest group, 75% volume reduction. So I think that's definitely worth a try. And these are all recent studies, because up until now, surgery, the moment you see an endometrioma, operate. But things are really, really changing. And recent studies are saying, try medical therapy, maybe Dynogest.
Sorry to interrupt, madam. You have 5 minutes to go.
Thank you. Deep infiltrating endometriosis, fortunately, I don't have to talk about much. We've had a wonderful talk just to tell you that it may be a different phenotype of the same disease. There are many different mechanisms going on in deep infiltrating endometriosis. But is there a place for medical management? Because unfortunately, not all of us can operate as fabulously as our previous speaker do. So we do have studies telling us that there is possibly not much of a role for medical therapy, but newer and newer drugs, progesterones with GnRH analogs with add-back therapy may cause amenorrhea, may have a role to play even in deep infiltrating endometriosis. One of the commonest problems we see is recurrence. And 6 to 67% of patients recur. So why? Important thing is, when we are talking about medical therapy, should we give preoperative therapy before surgery to prevent recurrence? And the answer, as you all know, is a big no, because it may mask your lesions prior to surgery and in fact worsen recurrence. But post-operative therapy definitely has a role to play for prevention of recurrence. So the moment you've done a really good surgery, removed everything, put the patient on progesterone, GnRH analogs, OC pills, levonorgestrel IUD, Dynogest, and expect a significant reduction in endometriosis. So we can all make our own flow charts on how we want to actually manage endometriosis. In fact, Foxy has also given recommendations very recently that avoid surgery as much as possible, try medical management always, and then as a last resort, go on to surgery. And really, unfortunately, there are many, many studies which are realistic looking at this and saying, what is the failure of medical therapy? And you can see that there are women who have no improvement with pain. There are women who have a recurrence of pain, 17 to 34% have a recurrence of pain, and they discontinue treatment. So we have to keep in mind that there can be failures, but there are also many, many successes. And so this very recent surgery paper again gave us benefit. Our results in this study, they said, do not benefit the preference of either medical or surgical treatment for treatment of dysmenorrhea and endometriosis. So both of them have an equal benefit. So which is why try medical treatment before surgical therapies. And I'm just going to end with these last few slides, because when the world says give up, hope whispers, try it one more time. And fortunately for us, we have beautiful new drugs, future therapies to try. We have anti-androgenesis factors coming up, simple drugs like cabergoline, which you all have used. We have statins like atorvastatin, which is anti-inflammatory and anti-angiogenic. TNF alpha blockers are now available. Infliximab is available to us. We have these peroxisome proliferator activated receptor gamma ligands available. Rosiglitazone is a simple word for this long, complex sounding word, which we have used and which helps in these conditions. Immunomodulatory agents such as pentoxifylline have been suggested. So fortunately for us, many new drugs coming up, which may have a role to play in this particular condition. Sorry, I'm just going to end with these one or two slides. The role of pharmacotherapy, remember, when you start treatment, it is across the lifespan of a patient. It is not a short period of time. So you can give conventional therapies, you can give emerging therapies. Important thing is that the field of endometriosis therapy is moving towards modifying the immune and the inflammatory milieu surrounding endometrial implants. And like I said, I'm going to bring to you the latest of the literature. So these are all things which have come out earlier this year that don't just focus on conventional. Emerging therapies are going to have a huge role to play, and always look at entire lifespan of treatment of endometriosis. So in conclusion, remember that Today, with all these wonderful diagnostic techniques available to us, exploratory laparoscopy should no longer be used to diagnose endometriotic lesions. Rely on ultrasound, maybe even an MRI. Do patient interviews, examination, imaging, that should be enough. No laparoscopy needed to diagnose. Instead of assessing endometriosis on the day of diagnosis, gynecologists should consider the patient's endometriosis life. Today you see her, tomorrow you want to treat her with a surgery. No, think of her entire life that she's going to live with this condition. Medical treatment is definitely the first line therapeutic option for pain and for those who do not desire fertility. Obviously, we haven't talked of fertility. That's a completely different situation. But if there is fertility required, think whether you want to do IVF before offering her surgery. And modern endometriosis management should be individualized with patient-centered, multimodal, and interdisciplinary integrated approach. So the more I live, the more I learn. The more I learn, the more I realize, the less I know. And I'm sure all of you realize there's so much more to learn for all of us, especially in this very, very difficult area of endometriosis management. Thank you.
Thank you so much, madam, for an excellent lecture, and trust you to make a dry subject so interesting and this thing. So if we can go on to the question and answers, we thank Dr. Mario and Dr. Rishma for the wonderful presentations. We have 5 minutes for the questions. So my first question to Dr. Mario is from Dr. Anil Magdum. How do you decide when would you do ureteric implantation in endometriosis?
Usually I decide to do the ureteral implantation when there is a total involvement of the ureter. So when there is a stenosis involvement of deep part of the ureter, so intrinsic lesions less than 2 centimeters from the bladder. So okay. If I have an infiltration less than 2 centimeters from the bladder, and it intrinsic one, there is no possibility to do an end-to-end reanastomosis of the ureter. So in this case, I do the resection of the ureter and the reimplantation. In case of the bladder nodule, probably the question was in case of bladder nodule, when I decide to do the ureteral reimplantation, I do the ureteral implantation from the bladder nodule only in case of intrinsic infiltration of the intramural tract of the ureter. In all the other cases, I try to do a conservative treatment and like in the video, opening of the bladder, removing of the bladder nodule, and respect the adventitia and the muscularis of the ureter, and try to avoid the reimplantation. And give me only 1 minute for congratulations for the other speaker, and a very wonderful presentation. And I totally agree with all the data about the medical treatment, and it's important to explain that in any case we have two kinds to do medical treatment, and when the medical treatment don't works and continues to improve the size of the nodule or involvement of the organs, in that case we go to operative room to remove the disease. I only disagree with one thing, not with the doctor, but with the literature. I think that in 2020 we cannot say more that laparoscopy is the gold standard for diagnosis of endometriosis. I really think that ultrasound is the gold standard for diagnosis of endometriosis. For when you have radiologist or gynecologist skilled in transvaginal ultrasound, they can see the millimeter infiltration of the disease. So we know exactly better, absolutely better than a laparoscopy, than a diagnostic laparoscopy, because sometimes during a diagnostic laparoscopy we can see only the superficial disease. You can you have no idea of the retroperitoneal infiltration of the disease. So the ultrasound evaluation is absolutely mandatory, and the diagnosis of deep endometriosis, or in general of endometriosis, I don't think is more by laparoscopy. So we have to avoid diagnostic laparoscopy. In my center, we do 1,400 laparoscopy for endometriosis. 90% of that are for deep endometriosis, not responsive to medical treatment. We never do diagnostic laparoscopy. We did the last diagnostic laparoscopy, I think, 10 years ago, because we have a team of people skilled in the diagnosis of endometriosis. And the accuracy of the ultrasound in, in good hands at the level of the bladder, at the level of the parametria, at the level of the bowel could be more than 95%. Our data is that we have 100% of accuracy at the level of the last 15 centimeters of the rectum, about evaluation of millimeter infiltration. So we decide what kind of surgery to do: shaving, discoid resection, or bowel resection, before to go in operative room. And we decide on the ultrasound evaluation, because we know that accuracy is 100% or very close to 100% for sigma, because at the level of the sigma, we have 96% of accuracy. So we decide before to go in operative room, we explain to the patients what kind of surgery we have to do, if shaving, if discoid, or if bowel resection. And I think the more modern strategy for deep endometriosis have to go in this direction. Sorry.
I have one more question for you, sir. It's that if there is, if you have somebody has used medical management for endometriosis, does it hamper the surgical outcome in terms of when you are operating surgically?
Absolutely. In any patients that we treat, we put the patients under the NHS medical treatment. And we do medical therapy until the surgery, and we do medical treatment after surgery in any case. Only if the patients want to go to pregnancy, of course, different there is a complication for medical treatment is absolutely different. And we had very good results with the NHS medical therapy after bowel resection. After 2 years of follow-up, we had no recurrence at the level of the ovary in all the group under the NHS medical therapy after surgery. In the group with estroprogestinic or estroprogestinic cyclic or in continuous after surgery, we had between 11 and 12% of recurrence at the level of the ovary in 2 years. And all the group with no medical treatment, we had 50% of recurrence at the level of the ovary in 2 years. In all the group, we had no recurrence at the level of the bowel after bowel resection. This is important. So in any case, we continue the medical treatment also during the recovery. We start before, during the recovery, and after the surgery.
Okay. My question to you, Dr. Reshma, is from Dr. Vidya Ramaswamy. Dynogest, does it cause a decrease in the bone mineral density, and your experience in this?
I did present a fairly long follow-up of Dynogest of up to 52 weeks and more, 15 months. And there is a known slight reduction in the BMD, but this differs from GnRH analogs, for example, because GnRH analogs cause extreme hypoestrogenism, and more than 6 months of use causes significant reduction in bone loss. And so you have to give an add-back therapy. Whereas with Dynogest, the bone loss that has been found to be reduced is very minimum. Once you stop the drug, it actually comes back. There is no heightened risk of fractures. And so other than lifestyle changes, tell the patient don't smoke, exercise regularly, have calcium, so vitamin D. Other than that, you don't need any extra precautions with long-term use of Dynogest.
Okay, we've had three people asking the same question. Dr. Nageshwari Nanda, Dr. Priyanka Thakur, and Dr. Neena Pachapurkar. What is the best drug for medical management in young unmarried ladies of endometriosis?
I think that's a huge group we are seeing today, and they're coming quite early, 18, 19, 20. And when you see them, you know that you're going to have to treat them for most of their life, maybe, unless at some point you're able to do a laparoscopic hysterectomy, oophorectomy, and radical surgery. So with that in mind, I think more and more trend towards progesterone as the first-line drug, with Dynogest being chosen as the first-line drug. And the OC pills, which we used to use very happily earlier, have been somehow relegated to second space because they seem to give only benefit from dysmenorrhea, not so much from the dyspareunia and all the other types of pain associated with endometriosis. Also, many people don't tolerate OC pills very well. Of course, we have to consider their requirement for contraception, how long they're going to take, and many times you have to mix and match, give one drug for a couple of years, start another drug, sometimes a surgery. So it's, I think, a mix and match, but typically recommendation would be Dynogest as first-line drug today.
Thank you very much. I think if I ask any more questions, Dr. Bhaskar Pal won't have any more questions remaining on the panel. So we thank Dr. Mario for taking out time from his, actually we are intruding on his family time. He's spending time with his kids right now. Thank you very much for sharing your time with us. And Dr. Rishma for giving such a wonderful presentation and for giving time for question and answers also. We move on to our next section. Thank you very much, speakers. We have Dr. Bhaskar Pal, who is the Secretary General of IAG, Vice President of FOCSI in 2017, President-elect of Bengal Obstetric Society and Gynec Society. He's the Chair for the AICC RCOG East Zone and Chair-elect for the AICC RCOG. So more than anything else, whatever I know of Dr. Bhaskar is he's one of the best persons to moderate a panel, and it gives more practical insight than on theory. So, and the other part is he never shares his questions with the panelists in advance. So it's always extempore. So that is what we enjoy. We have our panelists for today: Dr. Rajiv Laul, the President of TOGS; Dr. Datta Panandikar, Secretary General of TOGS; Dr. S. Krishnakumar, who's the Vice President and President-elect for IAG. We have Dr. Vivek Saunke, who's the Managing Council member of IAG, Dr. Sandesh Kade, who's also the Managing Council member of IAG, Dr. Manik Kade, who's a well-renowned IVF specialist and endoscopist in Dombivli and in Thane. We have Dr. Samir Pradhan, who's, if I don't mention him as an all-rounder, it'll be injustice. He's everything, but he's best known for his academics. Unfortunately, he's on the wrong side of the table. He's not allowed to ask any questions today. He's only going to answer, and myself. So I hand it over to Dr. Bhaskar Pal for continuing the session.
Thank you very much, Dr. Rajiv sir, Datta and Abhishek for inviting me. And over the course of the next 55 minutes, we are going to see that our panelists, which has an array of renowned endoscopic surgeons, how much Rishma has managed to convince them about to be more conservative with surgery. I know Manik is now doing only IVF. Dr. Krishna Kumar, I know, does both IVF as well as endoscopy, and Vivek, Sandesh, Samir and Abhishek are renowned endoscopic surgeons, especially with endometriosis. Dr. Rajiv and Dr. Datta, what about you?
See, we are obstetrician, gynecologist, and laparoscopist, and also infertility specialist, but not IVF specialist.
Okay, Datta?
Yeah, I think I'm more of an obstetrician. Do a bit of laparoscopic work. No IVF.
Okay, so we have 2 IVF specialists on the panel, and we have 4 advanced laparoscopic surgeons in the panel, and we have 2 generalists like me. So just to set the context that endometriosis affects around 1 in 10 women. In women who have dysmenorrhea, half of them will have endometriosis, and women who have chronic pelvic pain, 3 out of 4 will have endometriosis. So it is very important to think endometriosis whenever somebody comes with pain, especially the young girls. In subfertility, about 1/3 of them will have endometriosis. The reason that we have so many seminars on endometriosis is because the management is still shrouded in controversy as much as is the pathophysiology. The outcome is often unsatisfactory, and recurrence is almost assured. And complete resolution of endometriosis is not yet possible. And the current therapy has 3 main objectives. One is to reduce pain, one is to increase the possibility of pregnancy, and one is to delay recurrence for as long as possible. So in a particular woman, their aim would be any one of these 3 or maybe 2 of these 3. But I think what is essential to accept right at the start that the only guarantee in the treatment of endometriosis is that of a recurrence. With that, I'll start off. I've kept this case based, and a 21-year-old girl with severe dysmenorrhea, vomiting and bowel symptoms during period, no relief with analgesics. The ultrasound is normal. What would be your plan? I think I would take this question either to Dr. Datta or to Dr. Rajiv sir.
22-year-old woman, she's girl, she's married or unmarried?
Unmarried, she's unmarried.
So fertility may not be an issue at this time.
No, it isn't.
So we can investigate. Your ultrasound is already done. Ultrasound is normal. So there are no endometriomas to deal with.
Yeah.
So the basic problem is pain, severe dysmenorrhea with bladder and bowel symptoms. So we have to see, we have to do detailed USG to determine whether there is any rectal involvement, or you can also do PR to determine whether there is any rectal involvement there. So no relief is there with analgesics. So then we have to plan a medical line of treatment. And this being an unmarried girl of 22 years and with no question of any fertility, investigations, you can do AMH to determine her ovarian reserve, thyroid, and other hormonal evaluation. And I think she should get relief with Dynogest. You can start her on Dynogest 2 milligrams. That would be my plan.
Okay. I think.
Can I add something?
Datta, please.
Yeah. See, for number one, first try and find out who's done the ultrasound. Maybe you can repeat the ultrasound from a very experienced ultrasonologist like, say, Dr. Nitin Chaubal, who will probably not miss some implants. And you can, of course, think of an MRI, because there will be some implant which may be missed on ultrasound, which the MRI may be able to pick up. And I would agree with Dr. Rajiv Laul that I think in this case, like Rishma has also pointed out, Dynogest would be probably the drug of choice.
Okay, I will just be the devil's advocate. Why not the oral contraceptive pill to start with?
So I want to add something, sir.
Yes, Samir.
Yeah, I mean, sir, I personally feel one can always give a OC pill trial or therapeutic trial with an oral contraceptive pill in such cases. And we did not insist on a diagnosis, because there are some guidelines which say that if there's a unresponsive dysmenorrhea, one can always give a therapeutic trial of 3 to 6 months with a oral contraceptive pill. Only thing is, so we have to counsel the patient that we are thinking of this endometriosis empirical diagnosis. There is no role of any laparoscopic surgery because patient is unmarried. And if response to this therapeutic trial, we can continue the oral contraceptive pill.
Okay, let me sum up what we've learned. I think Dr. Laul and Dr. Datta both have highlighted one point, and that is the same point which Dr. Mario and Rishma have said. Laparoscopy is no longer required for diagnosis of endometriosis, and a good ultrasound should be able to. So as Datta said, make sure that the ultrasound has been done by somebody who's used, what the mind doesn't know, the eyes cannot see, who's used to diagnosing endometriosis on ultrasound. That's point number one. The point number two is there is a very, very important to do a bimanual examination. If the girl is unmarried, at least do a rectal examination, as Dr. Laul said. And number three, as all the three panelists have said, that this girl can be managed with medical management, and at least counsel them that we have an empirical diagnosis of endometriosis. You can start OC pills or Dynogest, whichever you prefer. The problem of starting OC pill is that the moment you start OC pills, the parents raise their eyebrows and thinking, why are they giving OC pills to my daughter? But the advantage of giving OC pills is it is cheaper than Dynogest. So the take-home message is good ultrasound, medical management, which you can continue as long as you want, provided the patient responds, and no jumping into laparoscopy at this stage. We have discussed all this, and that is exactly what Samir was talking about, that there are guidelines which we say that you do not need a conclusive diagnosis. You can give an empirical treatment of suppression of ovarian function. The RCOG and the SOGC both say that. I come to a very different situation, and in these days, I think Thane also has got a huge amount of IT hubs because on that side of that. And there are plenty of IT executives who are a migrant population, mobile population, and the company insists of doing health checkups once a year. And this is a 26-year-old IT executive who's married for the last 2 years, who's not planning a pregnancy. She went for an annual health checkup, and the ultrasound showed a left ovarian chocolate cyst of 3.5 centimeter. She has no history of pain. What will be your plan, Abhishek?
Since she has no history of pain, a 3.5 centimeter chocolate cyst, I don't think we need to continue with any medical line of management or surgical except for observation. If depending on what her plan of surgery is for, planning for fertility, we can get an AMH done just to check her fertility levels of AMH, and if required, cryopreservation if she's not planning for pregnancy for a long period of time.
Okay, Abhishek has said that she does not require any treatment. Let me go to Sandesh. Sandesh, would you like to leave her alone, or would you like to give her medical treatment, or would you like to operate?
Yeah, currently she is not interested in conceiving, but this endometrioma could be a potential damage to her fertility in future. So right now I would like to do an AMH, and then I would like to put her on medical treatment also, so that this disease does not progress, because endometriosis is a progressive disease. So definitely we would like to hold, and maybe if her AMH levels come low, she might change her ideas about conception. She might also go for egg storage at this age, 26, even if she's planning after 30. So a good number of eggs reserved would be a better option for her.
Manik, I want to bring you into the conversation. Manik?
I'm there. Can I speak?
Yes, Kumar, please.
All chocolate cysts may not be endometrioma. That is first thing. This is the first sonography. It could be just a hemorrhagic cyst with a lot of blood inside. So we would give her a medical treatment for 3 months, depending on whatever you prefer, either a COC or a Dynogest. And after 3 months, repeat the sonography, see whether it is resolved. Many a time it will decrease if it's not an endometriotic cyst. But doing an AMH is definitely an answer for knowing the AMH reserve, the ovarian reserve. But definitely one has to do a repeat sonography after 3 months of medical therapy.
Yeah, I think there is, I would say that we can take one of the approaches. We can either take Abhishek's approach or we can take Kumar's approach. Now, again, the very important issue is who's done the ultrasound, and a good sonologist will be able to differentiate between a hemorrhagic cyst and an endometrioma. If we are unsure whether it is a hemorrhagic cyst or an endometrioma, the best thing is to not do anything and repeat a scan after 6 to 8 weeks. And if that persists, then have this discussion. If we are sure it is an endometrioma, it's possibly a better idea to do an AMH, give her medical treatment, and counsel her about the effects on endometriosis on fertility. And then, as Abhishek said, that if she's not interested in fertility, discuss with her the option of social freezing. Manik, do you want us to discuss social freezing with this girl? Dr. Manik?
Yeah. Hello?
Yeah. Do you want us to discuss social freezing with this girl if she's not planning a child in the next 10 years?
next then, if she is not planning a child in next year, surely we should discuss about the social egg freezing with her. Initially, as Dr. Kumar said, we have to confirm that it is an endometriotic cyst, and we have to follow up because this hemorrhagic cyst also we sometimes miss for endometriotic cyst.
Right.
And when we follow up and we see that it is surely an endometriotic cyst, and if she is not planning for 10 years of her fertility, so we can go ahead with the social egg freezing and discuss with her that option. Okay. It's a better option for her.
Absolutely. I think for us generalists, I think the most important take-home message is that I always am a very firm believer, having a 21-year-old daughter. I am of the very firm opinion that I would be failing as a practitioner if I tell this girl that go and get pregnant now. My job is to counsel her about that what are the effects of endometriosis on fertility, and if she says no, career is now important, I'm not planning of a family, then give her the options of treatment, give her the options of a social freezing. I think that is social freezing is something which we miss at times. Talking about Kumar.
Yeah, no. Having an endometrium or not, at the age of 26, if somebody wants to delay for 10 years, I think everybody should go for social freezing then.
Okay.
It is not just endometrium.
I think I will start off with a 21-year-old college student presents with worsening dysmenorrhea, vomiting during periods with bowel problems. The ultrasound shows a 4-centimeter endometrioma in the left ovary. Vivek, would you operate on this girl?
This is an unmarried girl. Yeah, this is showing only a ovarian endometrioma, no bowel infiltration, right?
Yeah.
She could be given a trial of medical treatment. If she's not responding, then we can operate her.
Okay. I will change the question a little bit. The same patient. Ultrasound is normal. You have said that correctly, you've said that we'll give a medical treatment. That is what Rishma was trying to tell us, that even now, even with endometrioma, we always try to give her a medical treatment. But this girl, ultrasound is normal. Medical treatment has been tried for 3 months. 3 months of Dynogest has been given, and the patient still has dysmenorrhea, vomiting during periods, and bowel problems. Would you do a laparoscopy, Samir?
Right now, no, with the recent knowledge from the webinars, basically, if there's a bowel problem, there is a new thing which has come out that we have to do a good sonography after bowel preparation and pick up the bowel endometriosis if there. But if there is a worsening dysmenorrhea, not responding to medical therapy on Dynogest, then I will do a laparoscopy in her.
And what would be your aim at laparoscopy?
So now there is no role.
Let me clarify myself, Samir. What if before going to surgery, what is in your mind that what you might be expecting on laparoscopy, and depending on that, how do you deal with that?
Yeah, so basically the most common cause of peritoneal, the pain in endometriosis is not much as the endometrioma or anything more than the peritoneal disease. So peritoneal disease, if it is there, so if there is something like what we used to call mild and minimal endometriosis, and if this patient is having dysmenorrhea, the aim of laparoscopy will be to rule out other causes of chronic pelvic pain, like any adhesions. And if there is any mild endometriosis, earlier I used to ablate, now they say it has to be resected out. So it can improve the quality of life, get a definite diagnosis, and post-op after this surgery, one can keep her on a long-term Dynogest therapy.
Absolutely. I think what happens is that we all know that the degree of pain does not correlate very well with the degree of endometriosis, which means severe endometriosis might have mild pain, and you can get very, very severe pain with very mild endometriosis. And when we are operating for pain, it is always better, as Samir said, to excise, because with excision and ablation, the difference is there is no difference when you are doing it for achieving pregnancy. But when you are doing for pain with excision, there is a decreased recurrence rate of pain with excision. That will our aim should be to excise, and our aim should be to remove all visible areas of pelvic endometriosis. Vivek, and Samir said if there are any additions, divide the additions in rest of the anatomy. Now, Vivek, this patient had bowel symptoms. So irrespective of what the ultrasound said, would you be thinking that there might be bowel endometriosis before you operate?
No, we could do a MRI. A MRI and a sonography will actually tell us about the infiltration.
Okay, so if the MRI and the sonography is normal, you will not worry about it.
No.
Okay, and now suppose this girl has an endometrioma. Would you do a CA125?
Yeah, I do a CA125 in all cases. Even in that previous case of a hemorrhagic cyst and endometrioma, when AMH was done, I would have done a CA125 also in that particular case. Though it has no diagnostic significance, it just helps me to counsel the patient better if the CA125 is raised.
I think Kumar was saying
will always be raised and almost always be raised.
Okay. Now, this is a very interesting question. Kumar, your opinion of CA125?
No, CA125 I have stopped doing in any case of endometriosis. Definitely not required. You can counsel the patient by the sonography and the symptom which she has. The pain which has been affecting her, that itself will convince her on the sonography. And it is a myth that endometrioma does not usually exist alone. A recent paper suggests almost 46% of endometrioma are actually associated with DI, that is deep infiltrating endometriosis. So proper sonography, which we were telling, a rectal examination, even if she is unmarried, an MRI, as Vivek said, should rule out. And because the pain is there, definitely all these things have to be taken care in the surgery. But of course, an AMH will be done before the surgery to make sure that the ovarian reserve at that point is actually low or no, because endometrioma presence itself decreases the ovarian reserve.
Kumar, we'll talk about that later. This girl doesn't have an endometrioma. Kumar has said no CA125.
No,
yeah, also CA125, they have told now that also CA125 has no prognostic value in the progression or the resolution of the disease, which itself suggests that CA125 is not really required to be done.
Okay, I will come to that in a moment. I just want to know that after surgical treatment in this young girl, would you give her any post-operative adjuvant therapy? If so, what and for how long? Dr. Datta.
Yeah, I think this is what Dr. Mario has also said in his lecture. This girl needs Dynogest at 2 milligrams per day, and this has to be a prolonged therapy. It has to be for a minimum of 1 year, which will prevent probably the recurrence, which we are always worried about in any case of endometriosis.
Absolutely. I think what Dr. Mario said, that following bowel resection, they were giving Dynogest for 2 years as opposed to oral contraceptive for 2 years, and there was much significant less recurrence in the Dynogest group. So it is a good idea to give a post-operative adjuvant therapy. We've already discussed about her advice on marriage. We will not talk about marriage, etc. But this is just a slide to say how long Dynogest can be given. Yes, at the present moment, there are studies which have looked up to 60 months. Somebody was asking about issues about effects on bone loss. The bone loss is only important in adolescent girls. There's this Visado study which shows there's a 6% bone loss in adolescent girls, part of which it gets better after you stop the treatment. Now, this is a lady.
Can I add here? Actually, Dynogest is very expensive for 1 year, 2 years. Simple progesterone is equally effective, and the studies which have shown are on progesterone 10 milligram. But the problem we have is we give it like a cyclical fashion. That is wrong. It has to be continuous.
Yes.
Okay, Sandesh, if you want to give progesterone, I think unfortunately there is not many papers on progesterone. There is only 1 or 2 papers on levonorgestrel. In fact, there is more data on the oral contraceptive pill. And if for cost reasons I have to downgrade from Dynogest, I would rather downgrade into an oral contraceptive pill. And the oral contraceptive pill, if we give it, we should try and give it for as a continuous regimen rather than a sequential regimen.
Yeah, the message I want to give is it is continuous.
I want to come here regarding the oral contraceptive pill. Certain papers which I read, they increase the risk of DIE in later on in life. So how long can we give this oral?
The problem with the oral contraceptive pill is, as Rishma said, I think we never questioned the oral contraceptive pill before Dynogest came. We just started questioning it after Dynogest has come in. We say that it is very good in symptom control, but it has very little effect on the biological progression of the disease. So that may be DIE, that may be endometrioma. But I think if a patient cannot afford Dynogest, then something would have to be given. For older people, as Vishwa said, we can use a Mirena. For younger patients, we can always use the pill. I tend to find progesterones are also quite expensive actually if you have to give them in a high dose. Let's
Sir, even only progesterone pill also works.
Progesterone pill also works.
Yeah.
Now
it is also a better choice.
Now
for
this
young
is
unmarried
this is a 34-year-old patient who
Yeah.
presents with dysmenorrhea and primary subfertility for 4 years. Ultrasound shows a 5 centimeter right ovarian endometrioma. Now we've all said that we will do a AMH. Now my question is, I come back to CA125. We've heard that Dr. Krishna Kumar will not do a CA125 and Samir would do a CA125. Datta, you said you will not do a CA125. Abhishek, will you or will you not? No.
I will not do.
Dr. Rajiv?
No harm in doing one CA125. Occasional case of carcinoma, associated inflammation, tuberculosis, they also may be there. No? So follow up of the patient.
CA125 and ruptured cyst can go even up to something like
thousands.
Okay,
Yeah,
so
thousands.
let me hear Sandesh and Vivek. Vivek, would you do a CA125, yes or no?
So we do as a battery of test.
Sandesh?
Yeah, we do.
Okay. I think that CA125 has no role in as a prognostic feature.
Yeah.
A CA125 should not be used alone for diagnosis of endometriosis, but I think most of us are still doing CA125. Most of us doing CA125 because number one, it has become a habit. Number two, although in CA, and we will expect a modest rise, and we need to reassure them that the modest rise is because of endometriosis. But there are two situations where CA125 becomes significant. Number one, especially if there are any solid areas in the cyst, and you think that part of it looks like an endometrioma and part of it looks like a solid area. The other thing is that if the CA125 is in thousands, and even if the picture is very suggestive of endometrioma, that is when you get into problem. That is when I regret doing a CA125. We've had very typical endometrioma, and the highest CA125 I have seen up till now in endometriosis is around 20,000. The highest I have seen in tuberculosis is 35 to 25,000. Obviously, with that kind of thing, we had to do a multidisciplinary approach, and everybody said, no laparoscopy, you need to open with this kind of things. But the point is, I completely agree that doing a CA125 sometimes may be counterproductive, but I think most doctors are still doing one CA125 in cases of endometrioma. Now, all of us would do a test for ovarian reserve. Dr. Manik, AMH or antral follicle count?
Both the things are required for decision making of the treatment.
You should do
patient.
both. Okay.
Yeah.
Now, anybody who wants to give this lady expected management or medical management?
No.
Okay, there is
Sir,
no
34-year-old, no chance. Because
there's no expected management, no medical management. Now, Kumar, since you do both laparoscopy or ART?
Right. Now, in this case, it depends on the AMH and AFC count. One, if for some reason, if both are less, AMH is less, AFC is less, I would definitely counsel her for first ovarian stimulation and freezing of embryos, because she has got a low AMH and low AFC. And then I would do a surgery post pickup and then give her leuprolide depot and then operate her later. That will be the first line of treatment. If her ovarian reserve is good, and if she does not want to do the direct go for IVF pickup, then definitely a conservative surgery by laparoscopy will be done with all care to not to damage as much of cystectomy. We all know that cystectomy.
Kumar, I have a question for you.
Yeah.
You said if the ovarian reserve is low, you will stimulate, you will do a pickup and then operate. Why? Why don't you do a pickup and then straight away go for a transfer? Why you want to operate?
No. That is because she has pain. Number one, she has pain.
Fine. That is okay.
Number two, there are the cytokines which are around, the environmental factors which are all there, all inhibit implantation. So the moment you clear, everything becomes better.
I will change the question.
Sir, one more thing
Manik, before you speak, I will change the question, and both of you, I want you to respond. If this 34-year-old lady had presented only with subfertility and a 5 centimeter endometrioma and no pain, would you still do a surgery or would you straight go for a transfer?
No, I wouldn't do a surgery. We would give her agonist depot for 2 months and then transfer. After pickup, 2 months of agonist depot and then transfer. Definitely that has given better results, literature says.
Manik,
Yeah. My plan will be we have to first do IVF, do the freezing of embryos, do her surgery, and after that do her embryo transfer. Because with such a big endometriotic cyst, endometrioma, sometimes there is a changes in the endometrium because of endometrial receptivity changes in the phase of the endometrium to accept the embryo. So better is to freeze all embryos, do the surgery, and then do embryo transfer in after doing the surgery, immediately after doing surgery.
Okay, I have two take-home messages from here. Number one, in somebody who presents with three take-home messages. Somebody who presents with infertility with endometriosis, there is no role of medical treatment. Number two, if somebody presents with an endometrioma and infertility, if she has pain, that pain would be the only indication for surgery.
Yeah.
The second indication for surgery would be if the IVF specialist says that the endometrioma is so big that I cannot access the ovaries. I think it is easy for people who do both. For people like me who don't do IVF, any patient who presents with an endometriosis with infertility, I have a couple of IVF consultants whom I can blindly trust, and I manage the patient in consultation with them, because I think it is very important to have that opinion as well. Because many a times as doctors, we've been accused that if you have a hammer in your hand, everything in the world looks like a nail. If you're an endoscopic surgeon, you want to operate on everybody. And if you're an IVF specialist, you want to do an IVF on everybody. Sandesh, I want to bring you in. Yeah. This lady has got either she's got a normal AMH, or Kumar and Manik have picked up her eggs. So you're not worried about the eggs. So when you go in for a laparoscopy, what would be your aim? What would you be looking to achieving at the surgery?
Yeah, the prime aim is that I should not reduce her follicles. That is my, and while I am doing the cystectomy or whatever the treatment of the endometrioma. So the first thing is I would go from the base of the endometrioma and approach the punctum and drain the chocolate material, clean it. And then in this case, where it is a unilateral endometrioma and AMH is good, then I would prefer to do a cystectomy, which would prevent her recurrence. And also at the same time, I would like to see if there are any other causes for her infertility other than this endometrioma, which is very common to have distortion of the tubes and the tubo-ovarian anatomy adhesions in between. So we would treat that as well. And I would like to be very, very careful while doing the cystectomy, is be careful near the hilum and the infundibulopelvic ligament. So in these cases, we just make an incision on the lateral part of the ovary, find the plane. Anyways, whoever it is, there is no histological plane in endometriosis. So some ovarian loss is going to happen. So the only trick I follow is I don't use vasopressin so much in my practice. I rely more on being meticulous and going very close while we are peeling off the cyst wall. And hemostasis is very, very utmost. I would like to avoid too much of coagulation. Only I would irrigate it and find the precise pinpoint areas where I can coagulate, or even just compression with a gauze. That is what I follow most of the time. Or in the very severe cases, I can actually put a stitch also, one, not the continuous stitching of the ovary. Yeah.
Abhishek, you want to add anything there?
I use
in terms of the techniques of cystectomy.
Yeah, I prefer to use vasopressin. I find it that with the aqua dissection, the cyst wall almost peels by itself. So there is very obviously you do have to check for the hemostasis later on, but because of the aqua dissection that occurs between the layer, I mean, though you cannot have exact layers, there is a lot of times where if you don't put in the vasopressin and near the hilum, that is where the cyst is quite stuck. Whereas when you use vasopressin and aqua dissection, I find that it peels off very, very easily. And hemostasis also is better because the small capillaries which are which keep on oozing, except if there's a large oozer that you need to tackle, which I all agree with Dr. Sandesh. I use primarily pressure only compression for handling that, no coagulation, and as if required a suture.
Okay, I think all of us would do, I think Sandesh has said that restore the tubo-ovarian relationship, and all of us would do a cyst enucleation if it is the first time surgery, if it is unilateral, and if the ovarian reserve is intact. If the ovarian reserve is not intact, Samir, then would you do a enucleation or would you do a diathermy drainage?
Pardon me, I didn't get it.
If the ovarian reserve is compromised, would you do a cyst enucleation or a diathermy drainage?
So even if the ovarian reserve is compromised, if the patient has not agreed to Dr. Kumar's protocol, then I would like to use Done's principle, where I would excise part of the cyst, and whatever cyst is near the hilum, that I will just
yeah, but this is, this is a 5 centimeter cyst. It is very difficult to do the Done's principle on a 5 centimeter cyst. The Done's principle is very useful to do when it is a large cyst. Dr. Datta, would you give her pre-op or post-op GnRH? Let's go one by one. Pre-op GnRH, post-op GnRH.
No, I've never given pre-op GnRH before operating on any endometrioma. And post-operative GnRH will of course depend upon what her decision for fertility depends upon, whether she's interested in fertility or not.
Okay. Dr. Rajiv, would you agree to the pre-op GnRH, not giving pre-op GnRH?
So pre-op GnRH won't be required. Post-op, you can give GnRH to downregulate and then start the induction protocol.
Yeah, I think the only thing that says that there is a study which says that preoperative GnRH improves the American Fertility Society scoring, but there is very little clinical significance. So most people do not like to give a preoperative GnRH, or for that matter, any other pre-treatment before operating. The preoperative GnRH is only if the patient wants to postpone surgery for any reason. So ovarian, the classical teaching has been any ovarian endometrioma which is 4 centimeter or more should be operated. And if we do we can do a drainage and coagulation, or we can do a cystectomy. With cystectomy, what happens is there is less recurrence, but there is more ovarian tissue loss. Whereas with drainage and coagulation, there is more risk of recurrence, but less ovarian tissue loss. And there is, of course, less pain and less recurrence risk we've already spoken about. And this is where I think, Manik and Kumar, I want you to tell this. Every study says that after an endometriosis surgery, the number of eggs that you manage to pick up from the ovary reduces.
Yes.
But there are questions about whether that affects the take-home baby rate. There are some studies says that although it decreases the number of eggs which you can retrieve, it has no effect on the take-home baby rate. And some studies says no, it does affect the take-home baby rate. What is your opinion, your and Kumar's opinion?
No, most of the studies have now conclusively proven that definitely the drug injections are required more and the eggs may be less, but the take-home baby rate or the live birth rate is almost same.
Okay, so it is essentially
the cost becomes more. Yeah, the drugs are supposed to be more. That is the main difference which has been proven beyond doubt.
Okay. And this is what Samir was talking about, the Done's technique, and that is actually very useful for large ovarian cysts. What you do is aspirate, irrigate, and you nucleate the cyst till you get to the hilum. But because that is where the maximum ovarian tissue loss would happen. So you cut the cyst wall with plain scissors and then you vaporize at the hilum with diathermy or laser. There are people like Done's are very fond of laser. But if you see around 2-3 months back, one of our Indians settled in UK, his name is Gaurav Mishra. He has published his randomized trial of laser versus diathermy in endometriosis, and he showed that diathermy is no inferior to laser as in terms of operating on endometriosis. Dr. Rajiv?
Yes, sir.
We've already spoken about GnRH analogs. Anybody has any idea of giving preoperative Dynogest, or does that affect the surgery?
Preoperative Dynogest may mask the lesions, and after that, if you do the surgery, I think you will have to do ultrasound to detect the exact depth of the lesion. So you may not do the proper excision of the endometriotic tissue if you give prior treatment with Dynogest.
Okay. And Vivek, I'm coming to you this question because I know that you go and operate for a lot of infertility specialists. In an infertility with ovarian endometrioma, how would you go and decide whether which patient should have a surgery and which patient should have an ART? I think one we've already addressed, the presence of pain will be towards surgery and not ART.
Yeah, presence of pain and a sonography evidence of DI would be for surgery. And if it is a repeat procedure and a small endometrioma, we will not advise her surgery. If it is possible to do a IVF treatment without surgery, without doing surgery, the endometrioma is not coming in the way, then we would avoid surgery.
Okay, I think this is
For
a very
for a very large cyst where pickups and all are not possible. There we do surgery, but we avoid cystectomies in those.
Okay. All right. I will come back to that question again, but this is a very old 2006 paper, but I still love this slide, love this table. That you favor surgery if it is a primary surgery, if the ovarian reserve is intact, if pain is present, if it is monolateral disease, or if there are sonographic features of malignancy or rapid growth. On the other hand, you prefer ART if it is a recurrent disease, if the ovarian reserve is compromised, if pain symptoms are absent, if it is a bilateral disease and there are no sonographic or growth-wise worry of malignancy. Now, Dr. Manik, we say that if it is a large endometrioma, you might want to have a surgery done because it will be difficult for you to access the ovary for doing a pickup. At what kind of size are we talking about here?
More than 7 centimeter, 6 to 7 centimeter, because and if another side ovary is normal, then in that case, better to do the IVF, take out the eggs and then operate on that cyst, because another side of ovary with 6 to 7 centimeter cyst, after removal of that cyst also, we are not going to get any eggs from that ovary.
Okay.
Because not going to achieve any purpose by doing that.
Okay. But as Vivek said, that when we are operating to improve access for the IVF specialist, we would do a drainage and not do a cystectomy. Kumar, what is this sclerotherapy that some people are talking about these days?
No. That is not at all to be done. It is an unproven technique and definitely not for infertile patient. It is not recommended. I wouldn't want to do it.
Yeah, some people are talking about aspirating the cyst and injecting a sclerosing agent on laparoscopy. Sandesh, you are always abreast of new things. Please tell us.
No. Because now we are very often doing that sclerotherapy for IVF patients where AMH is reduced.
Yes.
What you do is we do not advise vaginal aspiration and vaginal procedure. You go by laparoscopy, 5 millimeter telescope. Do not dissect the ovary. Don't do any adhesiolisis. Directly puncture the ovary and aspirate the chocolate fluid and give a good wash. And then we put a sclerosant agent that is 95% ethanol and wait for 15 to 20 minutes. Then again aspirate and give a wash. It is proved that larger the ovarian size, more would be the follicular loss. So if you do sclerotherapy, the ovary will shrink. Now you have an option directly going for IVF, and it has been proved that sclerotherapy done ovaries give better number of eggs, and it is the results are already there are studies for that. So here you are not reducing her AMH, you are reducing her size of the ovary, and ovum pickup becomes easy. And because it is the distension which actually appears like 6 centimeters, 8 centimeters, when you aspirate it, it comes down to very small size. It becomes normal almost. It is stretched ovary. So sclerotherapy is far better than all your bipolar coagulation or lasers or cystectomy, especially if she is a case of infertility with AMH less. Sclerotherapy is the way currently and will be the way with good prospective study results coming up very soon in 4-5 months. Vivek,
what is your take on sclerotherapy?
I don't have any personal experience on that.
You don't have personal experience. Samir, what is your opinion on sclerotherapy?
I don't have any personal experience, but from the webinars which I attended, it is very good for recurrent endometriomas, where patient has been operated once and then there's just a recurrent endometrioma and she's not yet conceived. Then, that person who spoke on it, he spoke on the transvaginal method of sclerotherapy. Like on a TVS, he used the ovum pickup needle and he measured how much fluid was.
I think all of us have agreed that if we have to do sclerotherapy, it should be laparoscopic. Okay. Dr. Malik, you wanted to say something on sclerotherapy, I thought.
No, I was for sclerotherapy. I was telling that after doing that, we have never got any good eggs on the side of the ovary. But I don't have any experience of sclerotherapy.
Right now, on sclerotherapy on infertile patient, none of the infertility society internationally known recommended. They have not. These are individual small papers But
The
there are
regional
none
centers
of the
are doing it.
society, none of the societies
I
recommend it.
have a very, very standard take on all new therapies. I think new therapies should only be done in a controlled research setting before they are applied to clinical science. So at the present moment, yes, we need to watch the space for more data on sclerotherapy. Till then, in our individual practice, we should not possibly put sclerotherapy. Dr. Rajiv, primary fertility of 3 years, periods regular, no pain. You posted her for a hysteroscope laparoscopy, and on laparoscopy, there is 2 small endometriotic implants, one on the uterosacral, one on the left ovarian fossa. Would you leave them alone? Would you excise them? Would you diathermize them?
See, primaries of infertility is there. Periods are regular. So on laparoscopy, if we leave them, they may grow. They may become bigger later on. So it is better to cauterize them just now. Why leave them? And also search for any other areas, whether there are any other implants seen. And I think she must have undergone proper ultrasound before being posted for histolaparoscopy. So we should be sure that there are no other remaining implants anywhere else.
Dr. Datta, same approach?
Yeah, no, there are a lot of studies which say now that rather than cauterizing the implants, it is better to excise the implants, because with cauterization, the recurrences are high, and even the chances of adhesions are higher. So there was a time when we used to just cauterize these implants, but we have changed our outlook now, and we try and resect the implants rather than just cauterize them.
Okay, I have already said when we spoke about this in a situation of pain, if it is pain, it is always better to excise because the recurrence risk is less. But if it is infertility and you are only trying to improve fertility, whether you do a ablation or whether you do an excision, it actually doesn't make any difference to the fertility rate. But I think the most important point is exactly what Dr. Mario said. He said in his unit, 10 years, there has been no diagnostic laparoscopy. So I am very radical about the fact that there should be nothing called a radical diagnostic laparoscopy. Every laparoscopy is laparoscopy, and see and treat if you find something. Abhishek and Sandesh, when somebody, which means that these will be done a lot by not advanced laparoscopic surgeons. Any word of caution about excision of diathermizing these endometriotic deposits on the pelvic sidewall?
Yeah, ureter, one has to be very, very careful because these implants, what as mentioned here, are very close to the ureter. So one is you have to identify the course of the ureter, and then secondly, if at all it's on the ureter, one can do just put some fluid underneath and then coagulate also, or else better is to pull it away from the lateral pelvic wall if possible and make yes.
Abhishek, anything want to add?
Yeah, first, ideally, if you can, if it's not if whatever in this case, if you see if there are only isolated spots, usually if it's a thin patient, you can even see the ureter through the peritoneum. So that is a good way to identify the ureter. Like Dr. Sandesh mentioned, always pick it up in case you're not excising it. Ideally, you should excise it. But in case you're not excising it and you're only fulgurating it, you should pick up the peritoneum away from the lateral pelvic wall and only then coagulate. Don't blindly coagulate on the pelvic wall where the ureter could be injured.
I think there are 2 things about it. I think one is both of you spoken to us about. One is the ureter, and number 2 is sometimes you really do not know whether the nodule is deep and going into the depth. Once in a while, you will get a bit worried about that. You'll get fooled by that, and that is why I think whether you excise it, I think if you are excising it, you need to lift up the peritoneum in a safe place and make an incision and let the gas go in and then help your excision. Or basically, even if you are diathermizing it, make sure you pick it up well before you use a bipolar. And or as Sandesh said, you can inject some water.
I would like to come here, sir.
Yes, Samir, come. Please come in.
Can I just add?
Yeah.
Yes.
Which you describe, probably the doctor who is doing the surgery is not aware that there is going to be endometriosis. So he may not have taken a detailed consent. So I personally am a skeptical about excision, because excision, as it is shown, it is eroding much deeper inside. It will require a major surgery. And whether that surgery is going to benefit the fertility, we don't know. But it can definitely
Okay, I will talk about that. Again, I think that there will be, just like I do not believe that there is an operation called diagnostic laparoscopy, I don't think any patient should be consented only for diagnostic laparoscopy. If a patient is put up for laparoscopy, then the patient should be consented for probable procedures that might come in, which means that if we are doing a laparoscopy for pain, I think this patient should be consented for adhesiolysis, excision of endometriosis, etc. So if we are doing it for fertility, then this patient should be counseled for excision or ablation of endometriosis, adhesiolysis, etc. So that is where I think we different. So basically, if it's an infertility patient, it is easy. You consent her for a laparoscopy and fertility promotion. And within brackets, you explain to her that what are the common things that you might find that you might want to do. For example, if you find there is a tubal block and you want to do something about it, at that point of time, the patient needs to have a consent. So I agree with Samit that you should not do anything without consent. But I think the current scenario, you need to consent her about everything which is probable, because nothing you can do without consent unless it is something life-saving. But please understand, excision or ablation does have a benefit on the pregnancy rate, so it should be treated. Now I come to another situation. This is a lady who is 37-year-old who had a lap ovarian cystectomy for endometriosis 12 years back. She's had 2 cesarean sections, and now on a transvaginal scan, she had 4 centimeter chocolate cyst in the right ovary. Dr. Datta, medical treatment, surgical treatment?
So I think we have to leave the choice to her, because she's already had one laparoscopic ovarian cystectomy 12 years back, and she may not be very keen on surgery. It will depend a lot upon her pain factor. If the pain is too bad, then she will. But I would probably give her a trial of medical treatment.
And what would you try? What would you give?
I would give her a trial of Dynogest, definitely. 2 milligrams per day for 3 to 6 months to see whether it resolves the pain. If not, then I will counsel her for surgery.
Anybody who has a different take on it? I think Dr.
LNG IUD could be a good choice in this patient because she's already at 2 sections. And we know that LNG can definitely help in endometriosis. So putting her and let the period not come, and by that itself, a dysmenorrhea may reduce. Keep a watch on the endometriotic cyst every 6 monthly sonography. And if a menses stops coming because of the LNG IUD, she's happy because the pain dysmenorrhea is gone.
Okay, so I think before Dynogest came in, most of us would actually counsel this patient ideally either for an LNG IUS or for an injection Depo-Provera. But I think after Dynogest has come in, it made life much simpler because you've got a oral medication which works. It works pretty. And now
Bhaskar, I have a question here.
Yeah, please.
I think LNG has only local action. It will not produce anovulation.
No, it will produce.
Yeah.
Ovarian endometriomas, we don't put LNG for ovarian.
No, the LNG, what happens is that the LNG IUS will not decrease the size of the chocolate cyst.
Yes.
But it will not, it might prevent the increase in the size of the chocolate cyst. And that is why I do not prefer to use a LNG IUS right at the start. I have 2 approaches to managing this patient. I either start them on a Dynogest or on a GnRH analog. And once the cyst disappears, that is when I counsel them for putting an LNG IUS.
Right.
That is my way of going about it. Dr. Rajiv, I think you were trying to say something.
Sorry to interrupt.
I
We have
think
15 minutes to go.
fertility is not an issue. No? Hello?
Fertility is not an issue.
Fertility is not an issue. There is only history of dysmenorrhea.
That's right. And
recurrence. Pain factor is there. I think you can also try letrozole here also to reduce the pain. And of course, LNG IUS is also another option. So medical line of treatment, whatever she prefers. If she prefers Dynogest, if she prefers LNG IUS, or just for pain relief, letrozole, all these things can be tried in her.
My only problem with letrozole is with letrozole, you will have to give her either a pill or you have to give her a progesterone. And letrozole works better than many other molecules, especially when it is a rectovaginal endometriosis. So that is why I thought that it would be simpler to give her something like Dynogest.
I would share an alternate thought process here.
Yeah.
If the patient is not willing for a definitive surgery, then I would agree that I would give her first a GnRH Depo see that the size of the ovarian cyst is going to decrease, and then put a LNG IUD. But I would also try to counsel this patient that she's a case of previous 2 LSCS and she's having an endometriosis, which is a progressive disease. And now if she has completed childbearing, I don't see any harm in doing her radical surgery like hysterectomy with the removal of the ovarian cyst. And
no, 1 minute. We will do a hysterectomy with removal of ovarian cyst or removal of ovaries.
Salpingo-oophorectomy, yeah.
If you do a salpingo-oophorectomy, would you give her hormones?
Yeah, and then give a hormone replacement therapy.
And what if with the hormones she gets a recurrence of endometriosis pain?
Tibolone can be given, so which will not cause recurrence.
Which will not cause, pardon?
Tibolone can be.
No, I don't agree with that. There are studies which show that whether you use estrogen, whether you use estrogen progesterone, whether you use tibolone, the chance of recurrence of endometriosis after a hysterectomy BSO is the same. I think what has happened is worldwide at the present moment, if we look at the current literature and if we look at the last ESHRE guideline, is the current ethos in endometriosis is delay the first surgery as much as possible and reduce the number of surgeries as much as possible. So I think a better option would be in this lady to counsel. Of course, it is at the end of the day what she wants is to tide her over for a few years with medical management. And it is almost inevitable at some point of time. See, either she spends the money on Dianogus now and then has a hysterectomy, or she has a hysterectomy and then spend the money on hormone therapy.
Share one anecdotal case why this my thought process has changed this way. Because I had a similar case, and this dysmenorrhea and the pain has a very poor quality of life for these patients. And then they sometimes claim that just remove
Absolutely. I think that is where the question of individualization comes in. Every patient would have to be treated differently.
Let me complete.
Hello.
Samir, if there is no relief, you will do surgery. But first, you can always give COC also.
I think it is worth the medical management. If this patient has a poor quality of life on medical management, then of course we will take her for a definitive surgery.
Bhaskar, one more thing. This patient is 37-year-old. She has a recurrent. If the ovarian cyst on the same side where the previously operated, she can go for adnexectomy on that side.
She can go for an oophorectomy on that side. Okay, absolutely. I think we'll consider.
And if there is no adenomyosis in the uterus, then
absolutely. I think we will first try medical management and then we will try surgical management. And surgical management could be either adnexectomy on unilateral or clearance of everything. I just want to put up this slide. We do not have time to to talk about that how serious could be the magnitude of recurrence. But my last question would be to Vivek first and then to Sandesh. Now, recurrence can be with pain, with subfertility, or with an ovarian cyst, and I wanted to put it like that if it is essentially for pain, then we should start with a medical management followed by a laparoscopy. If it is subfertility, we possibly should go for ART. And if it is, and I want Vivek to take us through surgery for recurrent endometriosis. Preoperatively, intraoperatively, and that's it. What precautions will you take preoperatively, and intraoperatively, how would you go about it? Vivek first and Sandesh next.
For a surgery for DIE, sir?
For recurrent endometriosis, which might have DIE also.
Okay, recurrent endometriosis is a redo surgeries for endometriosis, comes in complex surgeries. We have to study the patient proper, whether the multidisciplinary team has to be involved. The urologist, the gastrointestinal surgeon is required, and then accordingly approach the patients. The gynec part of the surgery would be starting with identifying the landmarks, ureterolysis, creating an exposure for the operative field, doing a medial pararectal dissection and the rectovaginal dissection, and making the bowel safe. Bowel is safe, ureter is safe, then excise all the disease which is possible to remove. So it's a good excisional surgery which matters and which gives the patient a good relief.
Vivek actually made it sound very, very simple, that you just first identify the ureter, dissect the ureter, then dissect the pararectal space, and then safeguard the bowel and operate. Of course, it is one of the most complex surgeries. I remember that we called Sandesh to operate in Calcutta, and we thought we'd given him an easy chocolate cyst, and which turned out to be stage 4 endometriosis, which he beautifully operated. So, Sandesh, I want you to ask you three preoperative questions, and that is one which has come in the chat box also. One is, we understand that there is a risk of urinary tract injuries. Would you ask for any preoperative investigations for that, like an MR,
Yes.
urogram or something like that? That's number one. Number two is that in your counseling, would you discuss colostomy? And point number three is, how do you give bowel preparation for these patients?
Yeah, we have a very high reliance on MRI, because our ultrasound team, we are sure we just diagnose ovarian endometriomas and nodules, but we are very, very poor at diagnosing the bowel infiltration or the urinary tract involvement, especially the bladder is okay, but the ureter. So we rely more on MRI, and also most of our patients are of pain. So again, MRI is more useful for us than just ultrasound, because then with MRI, you actually know how deep the nodules have gone, and also beyond the pelvic brim, our ultrasound doesn't go. So we rely on MRI. That is one thing. Secondly, for urinary tract problems, which happens is we always depend on hydroureter and hydronephrosis, if at all it is there. That is a very, very significant marker for us, and then we explain the patient. The consent has to be very, very detailed, and the patient should be actually practical. She should be expecting what is possible and all the complications. Now, you asked about colostomy. If we have a nodule which is involving the vagina as well as the rectum, and if I am going to do a hysterectomy and bowel surgery, or if I am going to do a conservative surgery where I open the vagina and do bowel surgery, so there will be two suture lines very close to each other. In that case, we have to counsel her for an elective colostomy, that is ileostomy, not the colostomy. Secondly, if it is a very, very low rectal lesion, these are the lesions which can go into, they will leak and they can form fistulas. So very low lesions, we ask them to consent for colostomy. And previously multiple operations done and bowel treatment attempted, then we take consent for colostomy. So in all these cases, we are prepared. In urinary tract, hydronephrosis, hydroureter is a very significant factor for us. And this is how we go with the preoperative investigation.
And
all our
Sandesh,
surgeries, we go for bowel preparations. All surgery patients will be put, like these are planned surgeries. So we definitely put them on anti-inflammatories to reduce the angiogenesis and the nodule size and lesions. Secondly, bowel preparation is a must for all the patients, and we use peg leg, and we don't give enema in our center. So this is my preparation preoperatively.
Okay.
And soft residue-free diet.
okay, I have one question
But,
to you.
hello.
Sorry to interrupt,
But-
sir. 5 minutes to go.
Yeah,
5 minutes
I'm
to
coming
go.
back to you.
Yeah.
Sandesh,
Yes.
why did you say ileostomy and not colostomy?
Because it is easier. See, the upper part and the basically colostomy is a large bowel injury again. Sometimes we actually repair is difficult. The repair of ileostomy is easier. Secondly, these are loose folds of the ileum which is available for us to actually bring it up. Not necessarily you will always do a colostomy. There are some centers which just bring the ileum and fix it to the anterior abdominal wall as well. So depending on that, we prefer to do with the ileostomy.
Okay, I think the main difference between colostomy and ileostomy is that ileostomy is much easier to close. It is a much minor
Yes.
surgery to close. But ileostomy is much more difficult to manage because ileostomy has got a much more volumes coming out, much more liquids coming out. And a colostomy is much easier for the stoma to be managed at home. Vivek, anything you wanted to add to this situation?
So one more important symptom we should always ask the patient with uterosacral and the vaginal nodule is dysuria. This would suggest involvement of the inferior hypogastric plexus. So you remove these nodules and they'll end up in retention. So there have been some patients who have to be self-catheterized for some days. So this is an important symptom. We should ask the patient and counsel accordingly.
Okay. My last question to Manik and Kumar. Any special tips for recurrent endometriosis and subfertility?
Recurrent endometriosis and subfertility means if she's still infertile, then take her for straight away IVF if it is recurrent. That is the number one. There is no point in treating medical or surgical or conservative or but trying by simpler method. Straight away IVF in any case patient who has a recurrent disease. That is the primary and the only tip I think I will give.
Manik, anything?
Yeah, that is the one tip. And another tip is when they have a recurrent disease and you should always consider endometrial receptivity, I say, before going for embryo transfer in case of success in this endometriotic patient.
Okay.
Yeah, they all are given agonist depot pre-transfer. It is usually, then the results are shown even in adenomyosis, agonist depot 2 months gives good results. Then no, not giving.
Now, the last question is because Sandesh came up with an issue about decreasing the inflammation and decreasing the angiogenesis before a recurrent surgery. Now, what agent is used? Is Dionogest a good drug for that? Because we know Dionogest has got anti-inflammatory and anti-angiogenic actions. Kumar?
No, I believe in still agonist only because 3 months of agonist we give and all frozen pelvis we operate after agonist. Dionogest I have not tried. So I think agonist gives excellent plain and excellent less vascularity.
We rely mostly on either cabergoline or Dionogest.
Cabergoline or Dionogest for a month?
Yes.
Oh, I know somebody in Calcutta who uses Danazol for a month before operating. Vivek, you have any such fetishes?
Operating a DI patient, I would prefer the patient is off medical treatment for at least 2 months.
Abhishek, your views on this?
I also don't give any medical management prior to any of the surgeries.
Samir?
Not much experience, sir.
Okay. No, but you've been attending a lot of webinars. What means that is where you tell us.
Basically, what they say is preoperative general analogs depots is definitely not for any fibroid, but for endometriosis, I have not heard any such recommendation ever.
Okay. All right. I would end this with my take-home messages that individualize the treatment. In medical treatment, essentially all agents are equally effective, but they vary in side effects. And at the present moment, possibly Dionogest is the one which we get the most effectiveness with least side effects. Recurrence is common after medical treatment, and a short-term empirical medical treatment for chronic pelvic pain is acceptable. We should have a low threshold for laparoscopy. On laparoscopy, if it is for pain, we should excise. Whether if it is for subfertility, we can excise or ablate. In endometrioma, our primary aim should be to do a cystectomy. Post-operative adjuvant treatment, we do not give to correct an incomplete surgery, but essentially we give it for 2 years or longer as a secondary prevention. In early stage disease, pregnancy rates improved after surgery. In stage 3-4 disease, operative laparoscopy does improve the pregnancy rate, but not as, it is only when compared to expected management. But IVF does better than a surgery. And down regulation for 3 to 6 months prior to ART improves pregnancy rate. And essentially that is the only role of medical treatment in endometriosis. I will take a last word from each panelist, and of course I'll take it last from the president. So I'll start with the lady, Dr. Manik. Any last pearls of wisdom?
On
endometriosis, anything?
Endometriosis, Dionogest is the best medical treatment available, and ART is an option for the patients who have infertility, and we should have the decision making on the age of patient, AMH of patient, and what is the size of endometrioma, and according to the symptoms what patient have, we have to take the decision accordingly.
Kumar, any other take-home message?
Yeah, definitely the one who wants to treat endometriosis should be a good pelvic surgeon, which just Marcelo Manzoni mentioned, and also should have a good background of ART. These two combination will reduce the controversy on the management with endometriosis.
So manage in conjunction fertility and endoscopy. Samir?
Yeah, means counseling is very important. So in any of the earlier case scenarios which you see, one should counsel the patient, and if the patient is an adolescent girl, counsel her mother also that is an ongoing disease, and she one has to take the precautions at the right time, and also counsel them about all the options. If this is a newly, like the patient like the IT industry patient, we have to tell them about the future of infertility and ovarian preservation. So we should counsel.
Okay, Vivek.
Whenever we do get a sonography finding of a deep infiltrating endometriosis a nodule on the uterosacral area, always scan the ureter and the kidneys to rule out ureteral endometriosis, because it's a silent killer and it could cause a lot of damage,
And
silent loss of the kidney.
Many of ureteral endometriosis end up with the urologist as ureteric stricture, and they do not know what is the cause.
Yeah, many of times kidneys are not scanned and then we miss them.
Sandesh?
I might appear harsh, but actually, if you are not trained in endometriosis, please do not do endometriosis surgery. Let her first surgery be a complete and the only surgery. Reduce the number of surgeries. Preoperative diagnosis is a must. Invest in her investigations. She has to have a very good, well-informed consent, and she has to be realistic in her expectations. And thirdly, when we say that the disease does not coincide with her symptoms, then be sure that the disease is so big that her symptoms have suppressed and she's in a very late stage.
Absolutely. I think the similar message Dr. Mario has given, that you do not need laparoscopy to diagnose, you use your other imaging qualities to diagnose endometriosis these days. Abhishek?
Yeah, Dr. Sandesh has covered whatever I was going to say, but I just wanted to share one part is I've had, at least I don't count the number of instances, but innumerable of instances where as a freelancing surgeon, I've been told that this is a diagnostic laparoscopy. And when you put in a scope, it is come out as grade 4 endometriosis. So my take home message would be to completely evaluate the because the consent cannot be taken once the scope has gone in, and so a good evaluation in terms of the imaging as well as a good counseling for the patient before we go in, because putting in a scope and diagnosing endometriosis is not the way to go forward anymore.
Say no to diagnostic laparoscopy and image the patient well. Dr. Datta?
Not diagnosing deep endometriosis is sad.
Dr. Datta?
Yes, so I would say individualize the treatment depending upon her age, the symptomatology, the ultrasound findings, and the desire for fertility. And like Kumar and Sandesh said, if you're not competent, please involve a competent laparoscopic surgeon who can do a complete job so that the treatment is complete and the recurrences is negligible.
Okay, Dr. Rajiv, the last word always belongs to the president.
The journey of endometriosis to reach a proper consultant almost takes 7 years. So we all have to be much more aware of endometriosis as a diagnostic modality, when pain in young ladies not getting reduced by NSAIDs. So if we are aware of it, then we can start the proper treatment which was not available before. Dianogest is a treatment which is regularly available. In adolescence, we have to delay the surgery as much as possible. And as they are all saying that a general gynecological surgeon should not attempt this endometriosis surgery. You should call for a proper endometriotic trained surgeon, laparoscopic surgeon, to deal with these cases. And after that, you need ART support also. So it's a complete teamwork which is needed at every level. Combination of early diagnosis, good ultrasound, a trained laparoscopic surgeon, and also an ART specialist. All these are needed because this is a lifelong disease. It does not stop easily. And recurrent surgeries are known to happen very much in endometriosis. Thank you, sir.
Thank you, Abhishek.
Thank you.
And back to the convener.
Thank you, Dr.
Thank you, Dr. Lal and Dr. Datta and Abhishek, for a great webinar today. Excellent. Keep it up.
Thank you, Dr. Bhaskar, for an interesting panel and well moderated as usual, I may say. And our wonderful panelists, Dr. Rajiv, Dr. Datta, Dr. Krishna Kumar, Dr. Salonke, Dr. Kade, Dr. Manik Kade, and Dr. Samir Pradhan. It was a fantastic, it was a fantastic session. Good insights into the whole broad spectrum of endometriosis, along with our speakers from there. I hand over to Dr. Datta to give us the vote of thanks.
Yeah, thank you very much, all of you. A big thank you first to our young Turk, Abhishek, who has conceptualized this webinar in arranging for Dr. Mario, Dr. Rishma, a phenomenal moderation by Dr. Bhaskar Pal, who has covered each and every aspect. And a big thank you to all our panelists, Dr. Kumar, Dr. Sandesh Kade, Dr. Vivek, Dr. Manik Kade, Dr. Abhishek, Dr. Samir Pradhan, who unfortunately was kept very quiet today since he was a panelist. And thank you for all the members, all the people who attended this webinar. And a big thank you to Bayer Zydus, who was our educational partner for this webinar. And a big thank you also to IPLIT, who took care of the logistics. Thank you, all of you. I think we are meeting again the TOGS on the 13th of August for our webinar on medical legal interactions. Thank you very much, all of you. Thank you very much.
Thank you and congratulations.
Just 1 second. I want to take one photo. Thank you.
Thank you.
Thank you.
Okay, thank you very much. Thank you,
Thank you.
Sandesh. Thank you, Vivek. Thank you, Kumar. Thank you, Bhaskar, everyone.
Thank you.
Datta,
so
why
much, sir.
cap
Thank you,
is
sir.
on? Why is the cap on, Datta?
Sir is ready to operate immediately now. Within
Samir,
patient is